epidemiology of colorectal cancer. And we know from the statistics worldwide that the incidence varies widely between different geographical areas and different countries. So we have figures as high as 40 per 100,000 per year, and figures as low as 4. And colorectal cancer is well known with its geographical variation. When it comes to the sex, there is almost equal sex incidence, with some male predominance basically in the rectal tumors. The mean age is in the mid-60s, and these are the Western statistics. And this pie represents the most common cancers worldwide. These are the 2012 statistics. And we find that colorectal cancer ranks the third among all the cancers, preceded by lung and breast. When it comes to males, again, it is the third after prostate and lung. This is the colorectal cancer. And this represents the difference in the incidence and in the deaths between males and females. So as we mentioned, in males, it ranks the third after prostate and lung. In females, it ranks the third after breast and lung. As a cause of death, in males, again, it ranks the third, but after lung and prostate, because the mortality from the lung is more than it is from the prostate. And in females, again, it ranks the third as a cause of death, but following lung and prostate, as lung is worse than breast. Sorry, if I said prostate, I mean breast. Lung is worse than breast. So it is the third in incidence and the third in the cause of death, as a cause of death. So what about the Jordanian statistics? This represents areas, not only Jordan, and Jordan is part of Western Asia. And this is showing an incidence of something like 11 per 100,000 in males and 8 in females. Of course, this is the wild incidence. It is not age adjusted. If we make adjustment of the age, and this means that we take into account the age and what's the percentage of the population with that age, this figure in Jordan may rise to something like 18 or 19 per 100,000. So we are almost in the middle when it comes to the incidence compared to other countries. And this is the incidence in the when it comes to the rectum. So if you combine the rectum and the colon, it comes to something like 18 or 19. What about its rank in Jordan? It is the second most common cancer. In Jordan, it is number 2 in females, preceded by the breast, because the lung cancer is not as it is in the West. We don't know what will happen in the future with the widespread of smoking. In males, it is number 1, followed by the lung. So it is more than the lung and the prostate. So you have to remember this. Although we rank in the middle compared to other countries as an incidence, you have to remember that so far it is number 1 in males and number 2 in females. And the age is approaching the Western figures. However, we have to remember this point. We have something called the cancer in the young. And in colorectal cancer, the young means 40 and below. In the West, less than 5% of the cases occur in the young. In the young, I mean, less than 5% of colorectal cancer occurs in the young. In Jordan, this is almost triple that figure, and it can reach up to 15%. Now, what is the importance of this? Because we have a trend as physicians and healthcare workers to ignore the diagnosis of colorectal cancer simply because the patient is young. So in spite of the fact that the patient is presenting with enough symptoms to suggest colorectal cancer, we tend to ignore this diagnosis because the patient is young. And of course, the young patients will pay the price for this by having a late diagnosis and a worse prognosis. So what are the risk factors for colorectal cancer? The age. As we get older, especially the age of 50 and above, the incidence of colorectal cancer rises exponentially. Hereditary conditions like hereditary non-polyposis colorectal cancer and familial adenomatous polyposis. We'll expand a bit on these in a minute. So the hereditary non-polyposis colorectal cancer and familial adenomatous polyposis. A personal history of colorectal cancer in the past, or other cancers like ovary, endometrium, breast, etc. So any personal history of cancer in the past will increase the risk of colorectal cancer. So you have to take care of the past history of the patient. Family history of colorectal cancer. And the more you have family members, the closer they are to you, and the younger the incidence of colorectal cancer, the higher is the incidence of colorectal cancer. History of polyps, because we know that almost all of the colorectal cancer occurs on top of polyps. So if the patient is having history of polyp formation, you have to consider that he is at a high risk of colorectal cancer. Again, we'll expand on this in a minute. And this is how the polyps look like in the colon through colonoscopy, and the presence of ulcerative colitis. This will be the subject of the second lecture. So these are the risk factors. What is the importance of the risk factors? In addition to the fact that they are at a higher risk and they need more attention, if you are planning to do any screening program, and we cannot use the colonoscopy as a screening program for the population as a whole, because it is costly and inconvenient to do it at the population level. So at least you can start your screening programs with this group of patients or part of the population. So this is a patient with ulcerative colitis. So few words about polyps, because as we said, almost all of the colorectal cancer occurs on top of polyps. The word polyp is a descriptive term. It doesn't indicate pathology by itself. It is just like saying mass or ulcer. So different pathologies can present in the form of a polyp. However, when it comes to cancer, it is the adenomatous polyps that are important to us. So adenomatous polyps are pre-malignant. And we divide adenomatous polyps into sessile, where the polyp is lying on the mucosa, and pedunculated, where we have a pedicle or stalk. So sessile versus pedunculated. Pathologically, we divide them between villus and tubular. The villus are having a lot of fronts or fingers, زي الشعب المرجانية. The tubular are having less septations. However, we should not depend on the external appearance when it comes to pathological diagnosis. So tubular versus villus is a pathological diagnosis. So this is the gross and this is the pathology. This is how a pedunculated polyp looks like through the colonoscope, and this is the pedicle. And this is another polyp with a longer pedicle. And this is a sessile polyp. There is no pedicle here. And again, there is no pedicle here. So it's not related to size. Pedunculated versus sessile is related to the relation between the polyp and the cervix. Is there a pedicle or not? How do we manage polyps? We can remove most of the polyps through the colonoscope. So we introduce the colonoscope, and then we introduce this tube. We call it a snare. Once we reach the polyp, we open the tip of it, and then we tie it so it makes a circle. Then we apply a current, and this will cut the polyp, and then we can retrieve it. Now this shows the importance of the difference between pedunculated and sessile, because in the pedunculated, you can ensure complete resection of the polyp and complete pathological diagnosis. While in the sessile, like this one or this one, you cannot remove it completely because you may perforate the colonic wall. So most likely it's going to be a piecemeal excision, and the pathologist will not be able to tell you that there is a complete pathological examination. He will tell you as far as I can examine in the tissues I am having, but we cannot judge on the remaining tissues. So this is a normal colon through colonoscopy. Now, what will decide the malignant transformation of polyps? If this is a normal mucosa, and this is a polyp or adenoma, and this is cancer. So how do we go through this process from normality to frank cancer? The answer is through gaining mutations. So you need multiple mutations to change from normality to hyperproliferation to early adenoma or mild dysplasia to moderate dysplasia to severe dysplasia, then carcinoma in situ, then carcinoma, and then metastasis. So the more you go through this, the more you need the mutations. However, having one mutation will facilitate the development of further mutations. So the question is, or let's see what is written. So it's a gain of mutations. So how do we get these mutations? We can get them through hereditary factors or environmental factors. Now, this can explain the role of inheritance that we have touched on previously, and this will explain the role of the diet in the development of colorectal cancer. So what will the mutations do? They will either inactivate suppressor genes or activate oncogenes. And by the way, this applies to all tumors. Now, the APC gene is the one that is affected in familial adenomatous polyposis. The mismatch repair genes are the ones affected in hereditary non-polyposis colorectal cancer. So the malignant transformation clinically can be judged by the increase in the size, the increase in the villus component, and the severity of the dysplasia. So if you have a big villus adenoma and the biopsy is showing severe dysplasia, we are at a quite high risk of transformation to frank malignancy. So few words about hereditary non-polyposis colorectal cancer. It is an autosomal dominant mode of inheritance of colorectal cancer. The mutation is in the mismatch repair genes. The penetrance is high, which is how many of those with the genetic abnormality will change into a disease or phenotype. Of course, when we say non-polyposis, this doesn't contradict what we have mentioned that it occurs on top of polyps. Non-polyposis means the absence of familial syndromes. So it is not part of the familial syndromes like familial adenomatous polyposis. It can be site-specific, where the family members will inherit only colorectal cancer, or cancer family syndrome, where they can inherit different tumors included in the HNPCC, like the uterine, the ovary, the gastric, urothelial tumors, small intestinal tumors, and skin appendages tumors. So this is an example of one of our families, and you can see that there are different members in 2 generations. Many of them are first-degree relatives, and they include colorectal cancer, the yellow, uterine cancer, cervical cancer, and I think this is an ovarian cancer, I'm not sure. In general, colorectal cancers occur more on the left than the right, but in the inherited type, the right in them is more than the right in the sporadic. مش إنه they are having more on the right than the left. لا, they still have the left more than the right, but their right percentage is more than the right percentage of the sporadic. And of course, having the first mutation inherited there will be an early age of onset. You need to remember these two terms. They have higher synchronous and metacronous tumors. Synchronous means more than one tumor at the same time. And metacronous, the development of another tumor in the coming years. So they may present with tumor in the cecum and a tumor in the rectum, or a tumor in the uterus and a tumor in the colon at the same time, or they may have it in the coming years. Of course, these data are important when we design our treatment plan, but perhaps it is a bit more complicated for you at this level. It accounts for something like 6% of colorectal cancer. The second disease where inheritance plays a role is familial adenomatous polyposis, where the colon is studded with polyps, and they are different sizes and different pathologies. And if they are left, they will come with tumors like this patient and this patient. Again, it's an autosomal dominant. The inherited mutation is in the APC gene, which is located on chromosome 5, the long arm. Here, the penetrance is complete. Anybody who is inheriting the mutation will develop the disease. And this is important because you have to deal with it surgically before they develop the cancer. They start developing the polyps when they are in the teen of age. So if you examine them clinically before the age of 10, they will have no polyps. But of course, genetically, they will have the mutation. And then the colon will develop polyps. And by the end of the fourth decade, all of them would have had cancer if they are not treated. That's why we treat them by removing the whole colon and rectum before they develop the cancer. So this pie shows the different types of colorectal cancer. The majority are sporadic, but there is a percentage where there is a familial history but does not reach an inherited pattern. 5 to 6% are in the hereditary non-polyposis colorectal cancer category. The familial adenomatous polyposis around 1%. And then we have a quite rare other syndromes other than the familial adenomatous polyposis. So we said that we develop or gain the mutations through inheritance, as we have mentioned, or through environment. So what does the statistics tell us about the role of environment? Most of the statistics are telling us that the more fibers are consumed in a society, the less is the incidence of colorectal cancer. And the more the fat is consumed, including the fat in the meat, the higher is the incidence of colorectal cancer. That's why the medical authorities call for a balance between the use of fibers and the use of fat. So, what sort of data do we have about the diet? It was found that the carcinogen is not the fat itself, it's the bile salts present in the bile that we secrete in response to fat. So perhaps that these are the carcinogens. And how does the fibers help? They decrease the contact time with colonic mucosa by making the bowel motions more quick, or making the stool bulky and accordingly diluting the carcinogens, or binding with carcinogens, making them inactive. We have some epidemiological data telling us that the sedentary type of life is not good, smoking is not good, obesity is not good, and alcohol drinking is not good. We cannot say that these are causes, but they are more associated with colorectal cancer. On the other hand, we have some help from aspirin or calcium. Of course, most of these are having some explanations at the cellular and biochemical level. So how does the colorectal cancer look like grossly? We can have it fungating, like what we see here. We can have it stenosing, like what you see here, and we can have it ulcerating, like what you see here. And of course, from this you can imagine some of the symptoms that may occur because of these pathologies. Another example of ulcerating lesions. And this is when the tumor goes through the whole wall, reaching the serosa in the outside. So what sort of symptoms can be expected out of colorectal cancer according to what you have seen? Of course, it can be asymptomatic and discovered while evaluating the patient for something else, or during screening programs if there is one. The bowel habit, which is logic, because we are dealing with the colon. So any change in the bowel habit is important. And as you see, you should concentrate on the word change. Because even if your bowel habit is within normal, if there is a change, it is abnormal. And this can be diarrhea, constipation, or both, alternating. Change in the stool caliber, becoming narrower. Change in the defecation process, whether incomplete evacuation, tenesmus, straining, urgency, feeling of an obstructed outlet. So anything the patient can say that regarding his bowel that has changed may be the symptom of colorectal cancer. So you should not only wait for constipation, because this is what comes to the mind as we expect a tumor to obstruct the bowel. Number two, the blood. The passage of blood. Any form of blood. Not necessarily bright red, because you can have altered blood. You can have any color ranging from red to black. Mucus and abdominal discomfort. Again, we are saying discomfort, not necessarily pain. So it can be pain, fullness, cramps, bloating, nausea and vomiting. So in layman language, anything the patient says as I'm not happy about my abdomen can be a symptom of colorectal cancer. And of course, we have the general symptoms of weight loss, tiredness, the anemia syndrome, loss of appetite, etc. What about examination? Unfortunately, when it comes to colorectal cancer signs, if they are there, usually it means that the disease has been there for a good period of time. So pallor means that the blood loss has been there for a good period of time and significant. Loss of weight. Fever means that we are having some sort of complications. And jaundice means a liver metastasis. Again, loss of weight. Sometimes we can have symptoms and signs related to the spread of the disease. And this spread can be metastasis to the liver, to the lung, to the brain, or local spread, like this tumor in the rectum spreading to the urinary bladder, giving us recurrent urinary tract infection, fecal uria, nematuria, etc. A quarter of our patients with colorectal cancer will come to the emergency room because of complications. And this can include obstruction with its classical findings, pain, distension, absolute constipation, and vomiting. And these are the CT scans of that, showing complete obstruction with proximal dilatation. And this is the plain X-ray, and this is the tumor filling the lumen. Number 2, perforation. You can see the perforated colon with feces outside, and the perforation can be in the tumor itself or in the dilated colon proximal to that. For example, this is the tumor, and the perforation is proximal to it. And this is the peritonitis on top of perforation. And the third presentation to the ER, it is when the bleeding is massive. So, and of course, as I have mentioned, the bleeding is not necessarily the bright red. It can be anything between bright red and black. So not all the patients with colorectal cancer would come to the clinic. You may see them in the emergency room with the differential diagnosis of this presentation. So when it comes to massive bleeding, we have a long list of differential diagnoses. When it comes to perforation, we have a long list of differential diagnoses. And when it comes to obstruction, we have a long list of differential diagnoses. Again, signs can be some distension or even ascites when there is spread in the peritoneal cavity. You may feel a mass in the patient, and again, this means that the disease is a bit advanced. because a mass means that the tumor has gone through the whole wall to the outside. And as I mentioned, you may see the pallor. You may see a nodular liver because of metastasis or jaundice. And of course, you should include the PR examination in your examination because it can pick rectal tumors as long as the finger can reach, and you can see some blood on the tip of the finger. It's a pity to have a patient who is having his tumor spreading to the out or prolapsing to the outside. So as you see, we don't like to see signs in colorectal cancer because usually signs means an advanced stage. So what about the investigations? First, what is the aim of the investigation, or what are the aims of investigations? You have to remember these, and they apply to so many cancers as well. Number one, you need to confirm the diagnosis. Number two, you have to evaluate the whole colon, because we mentioned that you may have more than one tumor at the same time, synchronous tumors. You may have polyps. You may have an underlying ulcerative colitis. Then investigations to evaluate the extent of the disease or the clinical part of the staging. And then you need to evaluate the general condition of the patient, his hemoglobin, his cardiac function, his kidney function, liver function, carotids, etc. So what can you do? What sort of tests do we have? Always you hear about the fecal blood, which is the presence of occult blood in the stool. There are different tests for that. So a stool was put on this and a reagent was added and the color changed to violet, which means positivity. This is not diagnostic of colorectal cancer. All what it means is that there is blood. So this blood may be coming from colorectal cancer and may be coming from any source. So there is a high incidence of false positivity and false negativity, which can reach up to 30% of the cases. However, when it is positive, it is an indication to pursue with the evaluation of the patient. Barium enema, its use is limited nowadays. We put barium through the rectum, and then we have an X-ray, and in it we may see the apple core appearance, which means that the lumen has been occupied by the tumor except in a little bit of lumen in the middle. So the remaining apple is the remaining lumen, and the eaten apple is the tumor. Again, another example, a long stricture, again a stricture. However, as I said, its use is limited and it has been replaced by colonoscopy. Nowadays, colonoscopy is the gold standard test, although it is expensive, invasive, unpleasant. And this is the colonoscope, and I hope you visit the endoscopy suite. And this is the tip of it. There is light, there is lens, and there is the channel through which we introduce instruments. This is the position of the patient, left lateral, and this is the screen where we look at the camera photos. And this is a normal colon with nice vascularity and no lesions. And this X-ray shows how far you can go with the colonoscope, and you can even see the terminal ileum with it. So this is a normal colon. بكل أسف أنا كنت محضر فيديوز بس مش عارف شو المشكلة. This is a normal colon. These are multiple polyps, and this is a gross tumor. Now the colonoscope, in addition to the diagnosis, you can take biopsies to prove the diagnosis. You can remove the polyps, as we have mentioned. And in nearly obstructing tumors, you may put a stent to give a temporary relief of the obstruction. In some patients, where you cannot do a colonoscopy for one reason or the other, you can do a CT colonoscopy or colonography, which is a CT scan programmed to change the cuts into virtual evaluation of the colon, like the animation cartoons. And you can see lesions like this. This is a pedunculated polyp. However, you cannot take biopsies and you cannot remove polyps. So it has no therapeutic role. And this is a comparison between what you can see on colonography and what you can see on colonoscopy, the same lesion. And again, in rectal cancer, we may use the ultrasound, and it shows the layers of the rectum. This is the instrument. And you can see an ultrasonographic view of the tumor and where it has reached, how far it has gone through the wall, and even a nearby lymph node. As for the spread or metastasis, you can use CT scans, MRI, or ultrasound. Metastasis and local spread. So a CT scan can show multiple lesions or a single lesion of metastasis. This is an ultrasound of the liver showing a lesion. This is a CT scan of the lung showing a lesion. This is a brain CT showing a lesion. This is an MRI showing the tumor with its relation to the nearby structures. In rectal cancer, we like the MRI. The PET CT scan can show the metastasis in function. So this is a metastasis in the liver, and these are multiple metastases in the liver. So how do we stage colorectal cancer? Staging of colorectal cancer is basically a pathological staging except the metastasis or stage 4. So it is the pathologist who decide whether this is stage 0, 1, 2, or 3 after you resect the specimen and the lymph nodes. Metastasis will be shown with the investigations that we have mentioned. So stage 1 and 2 is related to the T in the T&M staging, and it depends on how far the tumor has gone through the wall. So a T is not the size, it's the depth of invasion. Stage 3 is related to lymph nodes, and stage 4 is related to metastasis. Don't be bothered by this long list. It's just to show you that T is not one thing. You have so many T's. Even when you say T3, there are more than T3, etc. All is related to the depth of invasion. And as you see, T4 is perforation into visceral peritoneum, that is the A, or invasion to other organs, that is the B. The N is the lymph node involvement, and again we have so many N's regarding the number, and in some other classifications there are some other points added to the N. So as you see, 1, 2 to 3, 4, 4 to 6, 7, etc. And the M is the metastasis, and again it is divided into one organ or more than one organ. طبعا هون don't be fooled by the word lymph nodes. المقصود بالlymph nodes هون far away. يعني مثلا مريض عنده supraclavicular lymph node ما بنعتبرها lymph node involvement، نعتبرها metastasis أو hilar lymph nodes. And out of the T and N and M, we have stage 1, 2, 3, and 4, and each of them is divided. But as you see, 1 and 2, it is related to the T. Once we have N, we go into 3. Once we have M, we go into 4. This diagram shows the percentage of colorectal cancer at presentation in regard to the staging at the presentation time. The light or faint color is the Western figures showing the distribution between stage 1, 2, 3, and 4. The darker ones are the Jordanian figures. And the thing that you can notice is that we have quite a few patients in stage 1, and what we were supposed to have in stage 1 are included in stage 2, but stage 3 and 4 are almost the same. And the explanation for this is the lack of screening programs or even any screening service at the time when we did this study something like 25 years ago. Although we don't have screening programs now, but we have some patients voluntarily coming for screening, so perhaps there is some sort of improvement in this. And in the March of every year, like this month, it is considered the Colorectal Cancer Awareness Month. And in March of every year, we expect to have activities related to colorectal cancer, whether for the public or for the physicians. How does it spread? It can spread directly to nearby structures like the urinary bladder that you have seen, through lymphatics to lymph nodes, that's the N, by the vascular route to the liver, which is number 1 because of the portal circulation, lung, brain, or any organ with a quite rarity. Transcoelomic, which is the spread in the peritoneal cavity giving deposits, and it is the cause for the ascites and the adhesions. So what's the treatment of colorectal cancer? Please remember this word. The treatment is individualized. So every patient is having his best protocol of treatment. And the treatment includes drugs, chemotherapy, immunotherapy. It includes surgery. As I said, the chemotherapy can include chemotherapy or targeted therapy, can be IV or tablets. It includes radiotherapy, and it includes some palliative maneuvers like radiofrequency or cryosurgery. So every patient will have his own protocol, but so far, surgery is the only mode or modality of treatment that can offer cure to the patients. But it is not the only treatment modality. And even when we say surgery, surgery is not one thing. You can remove the right colon, more of the right colon. This is called right hemicolectomy. Extended right hemicolectomy, transverse colectomy, left hemicolectomy, extended left hemicolectomy, sigmoidectomy, and for the rectum, anterior resection and abdominoperineal resection. So the surgery can be curative or palliative. You can do resection and anastomosis in one stage, or you stage it. Sometimes we are obliged to do it staged, especially if the patient is coming with complications. It may include a stoma, usually not, but it may include a stoma, and the stoma may be permanent or temporary. So as I mentioned, you can have right hemicolectomy, left hemicolectomy, sigmoid colectomy, anterior resection, abdominoperineal resection, total colectomy, whatever ectomy. Can be done laparoscopic or open, can include a stoma, temporary, permanent. So what's the prognosis? It depends on staging or on the stage, among other factors. So staging is not the only factor, it's the most important factor. And as you can see, the 5-year survival or cure rate, according to the stage, that's the carcinoma in situ, stage 1, 2, 3, and 4. And you can see how the 5-year survival or cure drops from 100 to 90% to 70% to 30% to less than 10%. I'm sure you will ask, how can we get a cure or 5-year survival in the presence of metastasis, even though this is a low figure? But how comes that this small group of patients survive with metastasis? The answer is because we started to do surgeries for the metastasis. So we started to resect livers, part of the lung, part of the brain, etc. So the prognostic factors include the stage, but there are other factors that are not present in the staging system, like the pathology. The staging system does not include the differentiation, the vascular and perivascular and perineural invasion and the mucinous type of the pathology. The chromosomal content, are we dealing with diploidy or aneuploidy? Because we know that the diploidy are having better prognosis. What about the technique? Have we done the surgery right? Did the patient present with a complication like perforation? Is the patient having more comorbidities? So stage is number one, but it is not the only factor. And that's the last slide. So if you have any question, so we make it a question exercise with some rest before we embark on the second lecture. Are you with me?
Yes, دكتور.
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 Any question?
لا دكتور ما في أسئلة.
مش معقول يعني كل هالحكي وما فيش فيه question.